Alrighty, so welcome to the Shut Your Mouth podcast. I'm Bree.
And I'm Amy. We are a health and wellness podcast with a heavy focus on sleep, breathing, and airway.
We will be chatting with leading experts, sharing patient journeys, and getting to the root cause of issues that are plaguing our society. So shut your mouth
and listen up.
All right, so we could not have a more fitting guest than the Dr. Ben Miraglia. I am so excited and honored that we get to sit down and pick your brain for the next hour or so. For the small chance that somebody listening in does not know who you are, Dr. Ben, let me give you a little introduction. So Dr. Ben has been practicing dentistry for 30 years in Mount Kisco, New York, or New Jersey, no, New York, right? Yes. And so a fun fact, when Dr. Ben was graduating dental school in 1993, Amy and I were turning 1 year old. And I only bring that up not to make you feel old, Dr. Ben, but I just really want to amplify the many decades of experience that you have. And 20 of those 30 years, you really took a big focus in early interceptive orthodontics and guided growth and development, making it so much of your passion that you are nationally speaking across the state, helping other dentists to start implementing this into their practices. You're the Vice President of Clinical Education for General Dentists for Candid Pro, the Chief Clinical Officer for Airway Health Solutions, and the one most dear to my heart and that I am so excited about is you're the Chief Clinical Officer for Tooth Pillow. And it is such an incredible honor to get to say I work alongside you and watch your passion every single day. So I'm sure I made some errors there, or there's a few holes in that introduction. So Dr. Ben, if you don't mind just elaborating and kind of sharing a little bit about what got you so passionate about this.
Yes. Yeah. Thank you very much, Bree and Amy, for having me on. It's going to be totally my pleasure to participate here and share what we've been up to for a long time. I did start dentistry about 31 years ago now, and I was for 10 years fixing teeth. And for 10 years, I fixed the teeth, and I was good at fixing the teeth, and I fixed a lot of teeth. But then I started to see in private practice, the kids were getting the traditional orthodontic technique, the braces. And braces, roughly between 11 and 14 is the window where kids are getting braces. And I have to say that I was dissatisfied with the results and the pathway. And I started to kind of question it. Is there a different way? Is there a better way? Are there alternatives to traditional braces from 11 to 14 years old? And some of the things that were uncomfortable were extractions of teeth. I really did not like extracting teeth. And so I'm looking at these poor kids thinking there has to be a different way. So 10 years in dentistry, fixing the teeth, but looking at children who are having traditional braces and seeing that if they get their braces off but don't wear their retainer, there's a lot of relapse, the fancy word for teeth are shifting back. And I think most parents understand what that is, because if you've had braces as a teenager, and then of course, what teenager could wear a retainer through high school and college? You lose your retainer pretty rapidly. It seems like 3 to 6 months is about the window. We throw them in the garbage or whatever, but then our teeth shift back. So we end up having to do it again. We're either getting braces again or we're getting aligners to get our teeth back. But seeing the relapse was very high. Almost all the kids would relapse. Then looking at extractions unfavorably, I just didn't see this as a good choice anymore. So here we go, 21 years ago, I started taking courses. So I hadn't learned anything about ortho, but I just figured out, well, let's try to see if there is an alternative. I started taking expansive orthodontic courses, teaching about growth, development, expansion, treating early. And so, oh my goodness, you can treat a child early between 3 and 11 years old. You don't have to wait until 11 or 12, and I didn't know any of this. So taking courses led to all of a sudden, well, now I have to do this. So I'm seeing that there's an alternative way. I have these instructors who are showing me their cases and what they've done for these kids. And I'm looking at similar children in my own practice. So I started treating right away, and I had mentors. And the mentors would help me early on to do nice work. And one thing led to another. And sure enough, fast forward about 10 years in, treating all of the kids we met from 3 to 12 years old and doing earlier work. Earlier work meant that all of a sudden there were no extractions being done or needed on any of the kids we treated. Then, of course, the earlier work meant that we were enjoying more stability, because the kids who we treated earlier, after a while, they were barely wearing their retainers, but their teeth weren't shifting back. So we started putting together some puzzle pieces. And then over time, you learn more and more about different things that are available to children. And then, of course, we feel like, hey, we should share this. Let's teach it. Teach other places. They might want to offer it to the kids in their community. So I started teaching this nationally in 2011. And then from 2011 on, fast forward, and we start to connect with other people. And next thing you know, we have people like Chad Rasmussen and Michelle Grasmick, and a Dr. Callie Hale and a Dr. Kevin Bowles. And these are some of the names that I'm listing are the founders, these co-founding members of Toothpillow, where the brainstorming was, well, this works so nicely in an office, but do kids really have enough access to this? What if we could do a remote or a pattern to deliver this type of care remotely? Is it possible? And sure enough, we figured out that it is possible. We built Toothpillow as a way to deliver what I was doing for 2 decades in my office remotely, so that any child anywhere, their parent could have access to the same type of care and opportunity to treat earlier. So in a nutshell, my story was dissatisfaction with the current traditional model of braces only later. And then, of course, extracting teeth seemed horrific and bad news for everybody that ever had it done. So I didn't want to do that. Learning about opportunities to treat earlier, then implementing it. Here we go, fast forward 20 years later, and we have had some incredible results, which over the course of this hour will share what my own experience has been over 2 decades of treating the kids earlier.
I love that so much. Thank you for sharing with us. So our podcast is called the Shut Your Mouth Podcast, which of course anyone in the airway space will understand why it's important to shut your mouth and breathe through your nose. But I'm still shocked how many people don't understand how detrimental mouth breathing is to our health. Are you able to list some of the effects that one might experience due to mouth breathing? I know we'll dive in deeper, but what are some of the things that breathing through our mouth versus breathing through our nose can cause for our overall health?
Yeah, there's a big difference between nose and mouth breathing, and they're not similar at all. They're actually opposites. So the nose is going to filter and warm and humidify, basically purify and clean that air perfectly. So when that air gets in the lung, then the lung can do its job well, which is the exchanging. So the lung is a big exchanger. Get the good stuff in, get the bad stuff out. But there's a way to do that appropriately. That's if the air comes through the nose. But if the air comes in the mouth, it doesn't get cleaned, filtered, humidified. It doesn't get prepared for the lung. So now the lung is going to do its job, exchange, but not at the same rate. So it's not as efficient. So here's what happens when we start breathing through our mouth. Well, one of the immediate effects is mouth breathing is going to dry the teeth. And when we take away the saliva, the protective coating, we're going to get more cavities. So children get cavities. And most people understand, well, if you're going to eat a lot of sugar, you could have cavities. This is true. And most people understand, if you don't want to brush your teeth, you're going to get cavities. This is true. However, the real issue is that the primary driver for kids getting cavities is the mouth breathing, with the sugar and the hygiene coming in second and third. So these are 3 factors involved with getting cavities: mouth breathing, sugar, and then poor dental hygiene. We don't brush our teeth. So we know children who parents will tell us, we only eat the healthy foods. We do not have sugar in our diet. We brush our teeth regularly. My kid gets tons of cavities. It's the mouth breathing. So you can get cavities without sugar and with all this. If you have no sugar and good hygiene, you can still get decay if you're mouth breathing. But if you're nose breathing, you can have some sugar and you can have poor dental hygiene and not get cavities by nose breathing because the saliva is protective. So we see the mouth breathing as a primary cause of cavities. But then, of course, beyond the cavities, it's the gums, gingivitis. Drying the teeth and taking away the saliva is also protective against gingivitis. So you'll see red and puffy, bleedy gums more often. But that's just what you see right here at the mouth. When we breathe that air through the mouth and it doesn't get prepared for the lung doesn't get to make its exchange properly. So what happens is it changes the balance of the ingredients in the body. And then the effects are seen in the digestive category. Breathing through the mouth will change how we're sleeping. It affects the quality of sleep. And it turns out that nose breathing is a pathway to have good quality sleep. When we're thinking about sleep for kids, we've got these 2 categories: quantity and quality. Quantity, the number of hours. Of course, we have recommendations from our pediatric medical people. What's the right number of hours children should sleep at their age group, right? Quantity is one thing, but quality mostly has to do with the way we breathe. So to have proper quality of sleep, we have to be nose breathing. Mouth breathing is not appropriate, and your brain knows it. So when we're mouth breathing at night, your brain knows to make adjustments to try to improve your breathing, but that's what disrupts the sleep. And next thing you know, we have disrupted or restless sleep. Disrupted restless sleep interferes with digestion because we're supposed to be digesting our food at night. Remember, the nighttime is the rest and digest component. And that's where we're in a particular mode of running where we're getting recharged, clean, set up for the next day. So all of a sudden we could have digestive issues, anything from the beginning, like reflux. Reflux is related to mouth breathing, poor swallowing, poor sleeping. And all of a sudden that will give you a reflux issue all the way to the other end where you could have something like a constipation or diarrhea. Gut trouble is part of the problem when we have poor breathing. The cardiovascular system, the heart with the vessels, it will function differently with mouth breathing. And it turns out nose breathing is what balances the ingredients that have our heart and our vessels running properly. So when we do have the mouth breathing starting, our heart has to work harder. So basically with mouth breathing, we're going to have a little less oxygen and we'll have a little less of other ingredients. And some of the other ingredients have fancy names like carbon dioxide and nitric oxide. But when we're mouth breathing, if we have less of those, it means our heart's going to have to work harder. And the heart has to work harder because it has to move the blood around faster to share the ingredients that are less of when we need to have it supplied to our body. When the heart works harder, that's called hypertension or high blood pressure. When the heart's working harder, it changes how a number of things are going to run. And sure enough, we could see symptoms downstream. And some of those symptoms past the gingivitis and the cavities are nightmares, digestive issues, waking at night, not being able to sleep through the night, grinding the teeth. Of course, things in the behavioral category. When we're mouth breathing and having poor quality of sleep, we might not get the proper rest. If we don't get the proper rest and aren't recharged for the next day, we might experience behavioral problems during the day. And so it's almost an endless list of the different things that can kind of malfunction for a child when we're mouth breathing at night while we're sleeping. And then, of course, when we think about mouth breathing while we're sleeping, there's a pretty good chance we're mouth breathing during the day. So even though we talk about how we're having poor sleep, usually that child is poorly breathing during the day as well as the night. So it's really a compounded effect of poor breathing leads to an unhealthy child.
There's just so many points there, Dr. Ben. When you were chatting, I just wanted to jump in and share a little bit as well. It's so insane to me that something as simple as the method of what we breathe can affect our bodies to such an extreme extent. And I didn't plan on sharing this a little bit, but it just feels really fitting when you were talking about the heart health. So Dr. Ben, I don't know if you know this, but I lost my mom when she was 59 due to sleep apnea. And one of the episodes that she kept having was in the morning when she would wake up, she would be a little delusional and not making sense. And so, of course, we rushed her to the hospital, and that's where we found out it was her CO2 levels. And so the way the doctors helped us as family understand was at night, not only is she not getting enough oxygen due to her sleep apnea, but she could not push out the bad. So she was not pushing out the bad air. And so it was causing an imbalance in her body. And she is the prime example of what happens when this goes untreated. She was around my age when she got diagnosed. She looked a lot like me, very semi-healthy, just this new sleep apnea diagnosis. And as the years went on and near the end of her life, she had diabetes, she had heart failure, she had all the things. And at the time, I had no idea that this was all related back to her sleep apnea, because that was the first diagnosis, the big thing, until I fell into this world of airway dentistry and connecting all the dots. And it made so much sense to me why she struggled, why she suffered for so long. And to be honest, Dr. Ben, it was this big weight off my shoulders, because I used to think I better have the best insurance my whole life because my genetics are not in my favor. And so now I know, no, actually, there's some stuff I can do now to help prevent that being the same path, not only for myself, but in my children, because I saw all of these signs, all of these symptoms in my two boys who are now in treatment. And I'm so thrilled that I'm getting to set them up for a better health, better future. And so I kind of was curious, Dr. Ben, for our next question is, what comes first? Does mouth breathing cause underdeveloped jaws, or does the underdeveloped jaws cause the mouth breathing? Can it be one or the other? Do you have an opinion on that?
I do. And it's very well supported by the research. So just to finish the points about what you were saying, it's heartbreaking to learn it and see all this happen in a parent, but the struggles do begin early in life. And so there is research showing that mouth-breathing children have cognitive impairments. And so it begins early. It wasn't that just at the end where at 59 years old, your mom was struggling with cognitive or having delusional type of things happening. It was early in her life where this began, and slowly she got worse over time. So for children, we know from research that if you're mouth-breathing at night, the research shows you'll have a lower IQ than nose-breathing at night. So children who nose breathe at night have higher IQs than children who mouth breathe while they're sleeping. That's significant research. The other one is in the medical research. The pediatric medical research shows that children who mouth breathe have the higher incidence of all the infections, whether it's ear, nose, throat, or lungs. So having the infections repeatedly over and over, and then the antibiotics over and over and over, that's treating the symptoms. So it does have an effect on your long-term overall health. And yet we have this research showing all of these things are related at an early age. Again, jumping back to the question at hand was the mouth breathing. How does this work? So sure enough, there is a large volume of anthropology research, which really helps put it in sequence for me. So anthropology research shares with us where we get malocclusion from. Now, malocclusion is the big, bad, fancy word, but it just means a bad bite, like smaller jaws. So when you have smaller jaws, you see crowded teeth. So anyone who has baby teeth, so 3 or 4 years old, the baby teeth, when the baby teeth are together and there's not big spaces, we know, oh boy, there's going to be crowded teeth coming. That's smaller jaws. It's really the foundation that's the problem. So teeth are the symptom. Foundation is the problem. So baby teeth together, bad sign. But permanent teeth crowded, bad sign. They don't fit. So if the teeth are crowded and don't fit and the bite is bad, malocclusion. Well, where does that come from? It's because the jaws are small. Now, when the jaws are too small, all of a sudden we see crowded teeth. But what's happening with the jaws is important. So the upper jaw, we have a fancy word called the maxilla. So our maxilla not only holds the teeth in here, what we also find is that when the maxilla is too small, it's really the maxilla that makes our nose. So we've got this triangle in here to breathe through. The air's going to go in and have to get in here. Well, this entire section is built by the upper jaw. So when the upper jaw is too small, we get a smaller nasal chamber. When the nasal chamber is smaller, we don't breathe well through our nose. Now, the pathway for breathing is we have to breathe in our nostril, and that air's got to go through a tube and get behind the tongue. So when the nose is too small, we struggle to breathe well through our nose. But also, when the upper and lower jaws are both too small, there's less room for our tongue. Well, when there's less room for the tongue, it sits further back because we want to close our mouth and we try to close our mouth. But now we've got this wall of teeth. We have teeth at the front and teeth on the sides. The only escape the tongue has is going backwards. So when the teeth are crowded or too close together, when we close our mouth, the tongue is driven back. But when the tongue is driven back, it blocks the air from getting behind it. So smaller jaws means it's tougher to breathe through the nose, and we can't get the air behind our tongue. So the smaller the jaws are, it's very likely your body's going to compensate for difficulty breathing. So, of course, the very first compensation for jaws that are too small is mouth breathing. Your brain knows the air's not flowing through my nose very well. I'll open the mouth to help you breathe. So mouth breathing is really like a form of basic survival. Your brain knows you're not breathing well enough through your nose, so we will open your mouth to let that air come in here too. It's a safety valve. Mouth breathing is a safety valve in case something happened to your nose that you couldn't breathe. That mouth breathing will keep you alive, but it doesn't mean it's healthy or should be done all the time. And now we know it's not appropriate to breathe through your mouth at all. Humans are obligate nasal breathers 24/7, 365 if we want to be in a healthy category. So the sequence of events is that the smaller jaws deliver the poor breathing. Now, the poor breathing can make the problem worse because there are groups that might say, oh, mouth breathing can make or cause a malocclusion. Mouth breathing is associated and can be causative of malocclusion, but we have to think about how do we get the mouth breathing? we didn't start necessarily as a mouth breather. We had to get that from somewhere. So this is where we talk about the anthropology research, meaning why do we recognize that almost all of the kids we see will be unable to have their teeth grow to place and have all 32 on their own? Because that's unheard of. That would be a unicorn today for a child to grow up and have all 32 teeth where they belong. So smaller jaws are very common. I see it in almost all of the kids we see. So where did the smaller jaws come from? It turns out there's a reason, a cause for this. The anthropology research shows that primitive, isolated, natural, aboriginal cultures, pre-industrial, pre-Western living. So pre-industrial, pre-Western living cultures, they transitioned from breastfeeding to hard food. So a natural human upbringing is to have hard food early. And so what happens with industrial Western living is the introduction of softer foods. So any culture that goes through a transition from early hard food to early soft food, meaning mush, baby food mush that we call it with a little spoon, well, all of a sudden the mush has an effect on the muscles. When the food is softer in the first 2 years of life, well, the muscles will be weaker. So when the muscles are weaker, the bones don't grow. It turns out the jaw bones grow primarily by the activity of the muscles. So when our muscles are working well, strong, and functioning properly, the bones grow well. So when you look at anthropology research, it shows that malocclusion or crowded teeth or bad bites, it doesn't really exist prior to early soft food. So you go back a few hundred years and all of the cultures around the world have well-grown jaws, 32 teeth coming together beautifully. But then when you track soft food in a culture, you can see, smaller jaws, crowded teeth. And today, every child pretty much has baby food early or pureed food early. And next thing you know, with the muscles being weaker, it doesn't promote bone growth. So a human being works by form following function. So if your function is proper, meaning hard food early, then your form will follow that function. You work hard to chew the food, your form will show it. You grow your bones. But when you have an early soft diet, well, of course, what happens is your form follows your function there too. The softer food gives you weaker muscles, and the weaker muscles will not help develop the bones. So when the bones don't develop, we see crowded teeth, but when the bones don't develop, we're also poorly breathing. So yes, there is a sequence of events. The early soft diet is the trigger for the weaker, and we use a fancy word, dysfunctional muscles, because weaker muscles don't function properly. They function differently. So weaker and early soft food, weaker and dysfunctional muscles, smaller bone growth in the jaws, and then you get crowded teeth, bad bites, poor breathing. Now, when you become a mouth breather, you already have the ingredients to have the underdeveloped jaws. You're a mouth breather because your jaws are too small and you can't breathe through your nose. Mouth breathing makes your bite worse. So when people say mouth breathing causes malocclusion, they're misspeaking just a little bit. So mouth breathing wasn't exactly the cause of the malocclusion. Mouth breathing is a result of having underdeveloped jaws or a malocclusion. But what mouth breathing does is it makes it worse. So mouth breathing is dumping a gallon of gasoline into an inferno that's already running. The inferno is already burning. So the sequence of events is early soft food leads to weaker dysfunctional muscles. Weaker dysfunctional muscles fail to promote proper bone growth. Now we don't breathe well. We have to breathe through our mouth as compensation. Mouth breathing is now adding to the vicious cycle, making us worse. So technically, mouth breathing can make a malocclusion worse. It's not exactly the cause. The cause, the undisputed cause of malocclusion by worldwide research, according to anthropology, and by them reaching out to genetics to back it up, is an early soft diet. The transition to early soft food causes this condition that we see in all kids.
So I'm super curious what your thoughts would be. Let's say genetically speaking, somebody has a mom and a grandpa and all the things with super tiny, narrow, high palates, all the things, but they become super educated in the airway space and they're listening to this podcast and hearing about soft food versus hard food and mouth breathing. Do you think that if they were on top of this from, birth all the way through childhood, that there's a potential they could change the outcomes of what that looks like for their child?
Yes. Yes, and not only does the research show that going from breastfeeding to hard food develops the jaws, and all cultures across the planet have always had excellent jaw growth and development in their history, except for when the soft food gets started. So there is a chance to redirect, but it's a tough one, because I can use my own personal example. My wife had to go back to work. So 12 weeks, she had 12 weeks off. Now, 12 weeks isn't really enough of the breastfeeding to be able to transition to hard food. 12 weeks is 3 months. But the anthropology research shows that the hard food begins 6 to 9 months old. That's as the infant can grab and bring to the mouth and gnaw. So if we have to go back to work at 12 weeks, then we're not supporting really a pathway for good growth and development naturally. And then we get to intervene, meaning can we help a child at 3 on to redirect? Yes. So if we were to have the credentials of, okay, I could exclusively breastfeed longer and then transition to the harder food, there are supportive tools for this. And one of the wonderful books we refer people to is Baby-Led Weaning. Jill Rapley and Tracy Marquette produced a beautiful book, Baby-Led Weaning, How to Introduce Your Infant to Solid Foods. And sure enough, the entirety of the human race had infants transition to solid foods. We could get back to that. It's the normal way. You just have to learn. We have to learn how to do that again. It's difficult. I didn't have that opportunity, of course, because with my wife having to go back to work, we went right to the bottles, right to the pacifiers, right to the mush. And so, of course, we did everything wrong. We did everything wrong for all those early years. And by the time they were 5, my kids, the baby teeth were together. There was no space. They were going to be a disaster. And I got started on them early. So I guess cultural change is very big. Like that's trying to, make a big change or a big turn. And I don't know if the circumstances are really set up for our success. While it's, a dream that if we could just change early enough, we wouldn't even have to have all these, terrible experiences with underdeveloped jaws. There are some who can do it. Wonderful. So we want to give them support to be able to do it. And then there are those who aren't able to. My family, as a particular example, couldn't do it. So we have to intervene. And luckily now we can intervene at 3. And I know you mentioned, because the mom has it or the dad has it and the grandparents have it. The reality is that, yes, all family members have it across all the generations, because when you think about the pathway to getting the crowded teeth, it's nearly 100% have underdeveloped jaws. And that only takes 4 to 5 generations, 100 years of using soft food for each generation to use it so much that almost all the people have it. So kids today in America are 7th and 8th generation post-industrial Western living. So the early soft diet began a long time ago. Now, 7th or 8th generation post-industrial Western living meant that the children we look at today have the crowded teeth and the bad bites and the poor breathing, but so do the parents. And so do the grandparents. And so do the great-grandparents, because when you go back, you have to go back 4 generations just to get to a 90% rate of malocclusion. So, you have to go back 100 years just to see some people have all 32 teeth where they belong. So it's very rare to meet a human being that has 32 teeth fully grown and developed, and they have no symptoms. They nose breathe, they sleep well, they're healthy, no medications, just a healthy human being. That's a thing of the past. So just to say that a child and a parent and a grandparent and a great-grandparent have the same credentials, that doesn't make it in the genes. That doesn't mean it's in your genes, because that's your environment. And in this case, with anthropology research and genetic backing up of the research, almost all malocclusions, underdeveloped jaws, crowded teeth, comes from the environment, which is that early soft food affecting the musculature, not the genes. Yeah, the genes play a very tiny role in malocclusion, almost negligible.
To add to that, Dr. Ben, so I worked in dentistry for going on 14 years now, and I myself, for many years, talking to our patients oh, you got mom's small jaw and dad's big teeth. We got some braces coming up, and that was just so common. And there are a lot of families right now listening to this, or they've gone down this rabbit hole. They are now educated, but then they're going to go back to their general dentist and share this information, and they're still going to be met with, no, that's not how this works, or, oh yeah, you have a tongue tie, but it's fine, leave it alone. There's all these things that they're still the dental community hasn't caught up. So what do you say to a family or a mom that has educated themselves, but now they have to advocate for themselves to get the help they need?
Yes.
What do you say to that?
Yeah, this is true. And it turns out that, at the university level, academia tends to lag 2 to 3 decades behind current technique or treatment. And so I can give a parallel to this. I graduated dental school in 1993, and I spent 4 years in dental school learning how to do silver fillings. And so silver fillings were the thing to use. I left dental school in 1993. I haven't used the silver filling in 31 years because nobody would use that again or wants that. That's an old thing. It's like asking someone to go around in a horse and buggy instead of a car. Like, that's the thing of the past. So academia and university teaching do lag the actual reality of, what the research and current stuff is. And so there are parallels across a lot of things. And like you might have mentioned about, you got, your mom's teeth or your dad's teeth and your mom's head. Like, mom's head is tiny, but dad's teeth are big. Like, I was speaking that way too. There was a time where we were doing this, but it was inappropriate. And I learned my lesson by reaching out and then learning about anthropology, and that, oh my goodness, I was misspeaking. There was a time where I was saying it's all wrong. Certainly there is no truth to that. That's a total myth. There's no such thing as getting somebody's big head and somebody's small teeth, or somebody's big teeth and small head. That's not how the human genes work, or really in any animal group. So even if a larger and smaller human were to, let's say, fall in love and make babies, we'll go with, let's say, gymnast. Gymnasts are typically tiny or short. So we're going to say a 4'11" gymnast. Very common to be that size as a gymnast, right? But a basketball player could be 7 feet tall. Well, these two people can have a baby, and it's not going to be deformed. In other words, you wouldn't worry like, oh, wait, a 5-foot person who has really short legs, but wait, the basketball player has really long. What if the child got the gymnast upper body, but the basketball player's lower body? So in your head, you're thinking, wait a second, can a human being get a 7-foot tall person's legs, but can they get the 5-foot tall person's arms? That's like Tyrannosaurus Rex type thing, right? The baby arms, but the long legs. Like that's not how things work. And it's the same in any animal group. Like a little dog and a big dog can make a baby, but a little dog and a big dog, you don't get the little dog's body with the big dog's legs. Like you don't get the big dog's body with the little dog's head. So genes don't work that way. And in the end, when you start to make these little comments, it becomes ridiculous that I was speaking that way. I felt embarrassed now of, oh my God, the way I used to say things. I'm humiliated and embarrassed. I used to think that, but I didn't know. I was told something and then I was sharing it. Meanwhile, it's not the case. The genes don't account for how, deformed your jaws are. It really is coming from the early soft food census, all in motion. So the dental office may not know. So what we talk to parents about is there is a chance you might have this experience where you go somewhere and you've said, oh, my child has X, Y, or Z, and you're told it's normal. They'll outgrow it. There's nothing to do about that. These are some of the answers that are given when they really don't have a way to help you or to treat it or to address it. So they tell you it's normal, let's wait, you'll outgrow it, all these things, but that's inappropriate. Then, of course, when you hear the opposite of what is true based on research and science, you do want to think about, am I in the right office? Should I explore another opportunity? And I would say you probably have to go ask for second opinion, third opinion, fourth opinion. Now, over the last 10 or 12 years, I have trained over 500 different offices to do this, and there are other people like me, I'm not the only one, who are teaching about early treatment, growth and development, let's grow the jaws early, and let's keep all the teeth, don't do any extractions. And there are people similar to me who do this type of education and train offices, so they're out there. But I would say at this kind of point in the curve, we're less common, we're in the minority, we are few and far between, but we are out there. And so I would encourage parents that it is okay to say no. In other words, I don't want any teeth taken out. It is okay to say, no, I don't want to wait. It is okay to say, no, my child is unhealthy. It's not normal, and it's not going to be something they outgrow. I want to have treatment now. Basically, what you're then doing is looking for an alternative, an office that does early treatment and will help you to grow and develop the jaws so that you can avoid waiting and avoid taking out teeth later on. That's always a bad choice. So there are people out there to find it. It can take a little searching. We hope one day that it doesn't take a little searching. We hope one day it's, unanimous across the board that people would just help kids earlier. And that's kind of why we got heading in this direction. So more kids have access to help early.
Yeah. And Amy, I know it's your turn, but I'm cutting because I wanted to
No, that's okay.
add to that. So you're talking about amalgam fillings. And so I taught dental assisting, and just a few years ago, and it hasn't changed, that part of the dental assisting curriculum is to teach them how to do amalgam fillings, because there are still doctors today that do amalgam fillings. And so these assistants have to know how to do it. So we teach them how to pack the amalgam and all the different processes. And so it just goes to show you that there are a lot of providers that are kind of still in the Stone Age. And so the question that's coming from this is, what are some red flags, or what are some things to look for a parent that's looking for a great airway provider, or a provider that's going to help them? What are some things to look for? What are some questions to ask? Is there any tips or tricks you can give a mom?
Oh, yeah, definitely. So, of course, it's nice to hear that someone might be an airway-focused or airway-centered type of office. That's nice. Those are good words. But then we do need to back it up with very good treatment. And so what we're looking to do is have an evaluation. Because first off, they do have to look at your child and kind of take some x-rays and take some photos and take some measurements and basically see, where you are, and then talk to you about that. So now you get to this consultation part where they're going to share what they're finding. So one of the things that we do look for is that the office actually went through what would be called a sleep breathing questionnaire. And so asking a lot of different questions, not just the standard medical dental history that you would normally get. It would be what we would call a sleep breathing questionnaire, where all of a sudden you're answering questions about, does my child snore? Does my child mouth breathe during the day or the nighttime? Does my child grind their teeth? Has my child had ear infections? Does my child bedwet? Does my child have nightmares? Does my child wake at night, or do they sleep through the night? Does my child have digestive issues? Does my child have anything in the ear, nose, throat, or lung type of infections in their history? Is my child struggling at school? Is my child having behavioral concerns, whether it's at school or at home? There's a long list of things, and they're all part of sleep breathing questionnaires. And so these sleep breathing questionnaires are for screening. So we're asking these things to learn, and if we're screening for this, which it is recommended from the American Dental Association that we do screen for sleep breathing issues in children, we're learning what their symptoms might be through screening, because then what we have to do is take a look at our photos and x-rays and information from the jaw development. Where is the child? Are they doing well with their jaws growing? And the office that is asking all the right questions like that, that's a good sign that they're asking to learn about your child in these categories that might seem a little outside of dentistry. However, those are symptoms that are downstream from poor breathing and sleeping. So we do have to make the correlations. That's a good step. The next step would be, it's okay to ask, because I recommend this to parents. How early do you start treatment? Because 3 is the earliest I start. And I am aware of some of my mentors who are pediatric dentists who started 2 and can even do younger. So, younger is available. I just get going at 3. I'm not prepared to handle a 2-year-old. So I've been okay at 3 and above. So the red flags might be an office that says, oh, we start at 6 or 7 or 8 or 9. If it's above 3, we're too late. And the parent can see for themselves, because one of the simplest things to look for in the baby teeth, do they have a gap between them all or not? And so there's a lot of research in dentistry early on that said, if you have gaps, big gaps between all your baby teeth, you'll do better with the permanent ones coming in nice. But if your baby teeth are together, we're going to have a lot of crowd on that. Baby teeth together are a sign of crowded teeth, bad jaw development. And sure enough, we need to help. So the office that says, oh, we get in at 3-4 years old, we're happy to start earlier. There are things we can offer at that age. That's wonderful, because waiting isn't helping the child. Then another question, which can sometimes generate some little bit of discussion, might be extractions, meaning what is your office positions, what is the office position or feeling on extracting teeth, baby teeth or permanent teeth? Because we do not believe that any child needs a baby tooth extracted or a permanent tooth extracted to help for spaces. I do understand kids get cavities. So when a child gets a cavity and it's so bad that you can't fix a tooth, there might have to be an extraction, because getting an abscess or an infection is But outside of an infection, an abscess, there is no reason to take out a baby tooth. So when we take out baby teeth to help permanent teeth come in straight, it's really a subtractive technique. That's not helping. So parents have to be aware that when we're taking out baby teeth for permanent teeth to get straight, it's usually that they're taking out the next tooth in line so that the teeth that came in can fit into a space that's too small. So it's kicking the can down the road. The only time that I would say I would consider taking a baby tooth out is when the baby tooth is in there for you to see and the permanent one is behind it, like right behind it, the one that's supposed to replace it. Then it's okay to take away the baby tooth so the permanent tooth can be there. What we don't want to do is we've got 4 crowded permanent teeth. The lower 4 teeth are crowded. We don't want to take out the next baby tooth in line. That's baby tooth number 5. And on this side is baby tooth number 6. We don't want to take out the baby teeth on the sides of the 4 teeth. Then you let the 4 teeth spread out. And while the 4 teeth look better, we have 4 teeth in a space that had 6 baby teeth. That's not a good math problem. So we're heading the wrong way. So we don't take out baby teeth to make room in the arch width. We can take out a baby tooth if it's in front of or blocking a permanent tooth in front of. So that's okay. Permanent teeth, it's a never. So I can tell you my experience in now 21 years, we have never extracted a baby tooth to help the permanent teeth aside from the one that's in front of it, like we just described. And I've never taken out a permanent tooth for any child. And we've been treating children exclusively now and consecutively for 21 years. So we don't take out any permanent teeth either because our pathway is grow the jaws early, treat the teeth second. Foundation first, teeth second. Get the jaws to the right size and guess what? All the teeth fit. So not only can you keep all the teeth and there's never a need for extraction, that always is a red flag when an office says, oh, you might need extraction, we have to take it. Then you know you're in the wrong place. So you don't let anyone take out the baby's teeth and don't let anyone take out the permanent teeth till you've had another opinion. Further than that, turns out if you work earlier on the kids from 3 to 7, the earlier age range, the better, because you can get the jaws to the right size and have opportunity for all the teeth, including the wisdom teeth. So at our office, since we're 21 years in, I can tell you our experience is that most of the kids that we treat earlier have their wisdom teeth come in later on. So they have 32 teeth. What a nice thing to have all the body parts where they belong. So I'm not a fan of, just taking out wisdom teeth, but I understand they can cause problems. So when they're really crooked, causing infection and problems, yeah, there's reasons to take them out. Of course, they can cause damage. But how about if we got involved earlier to keep them? So when we treat the kids earlier, we have now the experience of most of the kids we treat earlier have their wisdom teeth come in and without issues. So they have 32. So we're a big fan of that. So parents need to hear or look for, they're asking a lot of good questions like a sleep breathing questionnaire about their child's health symptoms they might be experiencing because there are relationships. Now that doesn't mean the doctor's treating those things. So we want to make sure we understand we're in the dental community. So in my office, while I might be asking about your child's behavior, and I might be asking about ear infections, and I might be asking about bedwetting, that doesn't mean I treat those. So I don't treat ADHD, I don't treat bedwetting, I don't treat ear infections. But when you look at the research on those things, yes, Dr. Karen Bonnick showed us in beautiful research that behavior has a correlation to how you sleep, which is your breathing issues. So sleep disorder breathing children, thanks to Dr. Karen Bonnick, had cognitive issues, lower IQs. Sleep disorder breathing, thanks to Dr. Karen Bonnick, showed us behavioral issues are related to the manner in which you breathe. So the worse the child's breathing at night, the worse the behaviors are. There's a correlation. So what am I treating? I treat when I diagnose. I diagnose the underdeveloped jaws. Malocclusion is something you can diagnose. So I'm a dentist. I stay in my lane. I diagnose malocclusion, underdeveloped jaws. It just so happens that screening is the earlier part. We screen for symptoms children might have, but we diagnose what we can treat. So I don't treat what I screen for. I treat what I diagnose. When you grow the jaws and you get the breathing to improve, then your sleeping can improve and the symptoms can fade away. So it is my experience that kids who are bedwetting regularly will stop when they breathe better at night. Kids who have multiple ear infections will get less or no ear infections when they breathe better at night. And then, of course, the kids who have behavioral problems and maybe have medication or have been recommended medication, when we have the proper jaw growth and they breathe better, sleep better, the behavior changes. And if the behavior improves, maybe they don't get or need the medication anymore. So we have those experiences in all of those categories. But again, it's important to know that I don't treat or, diagnose those things. We screen for those things so we can have a full overall health conversation with a parent that there are relations to these things and we want to help your child, but we have to focus on what we know is our issue. So parents should know that there are offices out there to help them, but be careful. I wouldn't let anyone ever take out a tooth on a child without pursuing other alternatives. And the other red flag would be waiting. Waiting is not going to help you. So extracting teeth, very bad. waiting very bad. Your child needs to be treated earlier to help them. And so you're looking for someone who is willing to treat early. Last but not least, it's okay to challenge the office to show you examples. Show you examples. Show me someone you treated similar to my child. You're telling us that you do airway and growth and development and treat 4-year-olds. Show me a 4-year-old that you treated and the outcome. Show me a pathway that you can do for my child the same. And the offices should. They should have examples to show you, and they should be proud of their examples that they're doing this wonderful treatment and helping kids. So feel free to ask to see examples of treatment. We do that a lot, because we want the parent to understand, here's a 3-year-old that's like yours, and here they are when they're age 10, 15. I mean, now I have this 2-decade volume of information. I can show these kids in their 20s with their wisdom teeth still doing beautifully, and they're not even wearing retainers anymore. So over time, you get a bigger volume to show.
And I think that part of the missing piece too is the progress down the line when they're able to age appropriately and have that proper growth and keep their wisdom teeth. I know that you guys know a bit of my personal story with my son, but I researched, I went to multiple different, dentists and orthodontists and went to the top airway orthodontist in the state and was seeing these beautiful pictures of the expansion, but I wasn't seeing like what happened down the road. And now that I know more about that, this dentist or orthodontist in particular did upper expander only. And it just, as soon as that was taken out, because we didn't address any of the other issues, my son relapsed. And so what you were talking about, Dr. Ben, I don't know if you even know this yet, but my son had a super tiny mouth to begin with, was expanded, things looked great, we did braces, and then as soon as that came out, he went right back to starting point, and now he actually has an adult tooth growing in where the baby tooth is still there. So his mouth is still so incredibly tiny, and just having the tools and resources for these parents to go into their dentist, to know what they're talking about, to feel confident in that, to have the questions to ask is so important. But then also just knowing, your intuition, your gut instinct, that even if they have, the flashy sign that says they're an airway dentist or an airway orthodontist, if there's a red flag in any of these questions, or you're feeling like it's not the right thing for your child, to just know and understand that maybe the dentist isn't quite there yet. Maybe they don't have a full understanding of how all of the things work together. And that's the point where you leave and you find someone else, because sometimes ego might be in the way. They might not be able to fully understand at this point in time how all the pieces fit together. So I love that you listed all of the questions that moms and dads should look for when they're trying to find the right provider for their child.
Yes. And I'm glad you brought up your son's experience, because I feel like there was a pathway to get to that at some point, that parents should be very careful with an upper expander only technique. And I don't say that loosely. It's actually based on the research that was done. So there was a large volume of research done on early treatment. And the early treatment involved a few things, but the primary course or primary treatment option for early treatment in these research projects was an upper only expander technique. So the kid got an upper only. Well, the outcome, when you follow it, is that it's very common for the upper expander to, while it's being turned, make wider. Of course, you're turning something, so it's wider. But when you take it away, the research had the overwhelming conclusion that early treatment is not effective because it's going to go back. And so I get that conclusion because if all of these research projects showed that we did this early work, but it doesn't hold, it has no stability, it's going to go back. One conclusion would be early treatment doesn't, but we could be a little more clever about it and think about, well, what was used? What technique was used? And it turns out all of those projects involved upper expander only. So a more accurate conclusion might be, an upper expander only is not so effective, because early treatment is effective. It has to have certain components to it. So I'm a big fan of early treatment. I do a lot of early treatment. I don't see my kids relapsing, but we would never use an upper only expander. We have to have both. Some kids need expansion, and there's nothing wrong with expansion, but you do have to have upper and lower. So when a parent hears that their child is going to get an upper expander only, you will realize this pathway almost all of the time. It will be a little bigger during expansion, but when it comes out, it's going to shrink back to match the bottom because the bottom wasn't changed. Now, the bottom does not catch up over time when we're talking about width. The bottom sometimes has a chance to catch up forward growth over time, the lower can go a little bit further, but we still have bites where the lower teeth are further back behind the bottom, behind the upper. So the catching up part isn't really a real thing, because in order for the lower to catch up, the upper has to remain wide, but the upper doesn't remain wide. It kind of shrinks back to narrow. So when parents come to see me and they state, oh, we've had an upper expander already. We had phase 1 or early ortho. They had an upper expander. Well, we look in there and the teeth match up, meaning the top and bottom back teeth fit together. So the top isn't wider than the bottom. It's a match. Well, if it's a match and they had an upper only, the outcome is usually that the upper was a little wider during the expander and it came back to match. So I have the experience in my practice of seeing the research prove to be accurate. The orthodontic research shows early treatment is ineffective and unstable. However, more specifically, when you dig through it, it's an upper expander only. Ineffective, no stability. So the kids come in at a later date and they have the same credentials they had before. So it's no surprise they still have all the sleep and breathing credentials, the symptoms. And it's no surprise the teeth are still crowded and coming in poorly. And then, of course, we can go a step further, which is a lot of the children who have this upper expander only technique, the research was done for a particular reason. And that research was done to show that early treatment's ineffective. It's what became the rationale for treating at 11 and above. So when we think about the orthodontic specialty in braces, it's recommended to treat at 11 above because that's the best window when all the teeth are there. You want to get rid of the baby teeth. Don't do anything early. Why not do anything early? Well, because it doesn't work. But it didn't work because we were thinking about that research a little more closely, in that if they had an upper expander only, they have nothing to gain from it. They're the same measurements. So what happens when a parent gets the models, like the original model that they had when they went to that office, they had an expander made, they had expansion done, but now they're in my chair. Well, guess what? The child in my chair has a measurement across the arch. Their width is the same as the model at the start before they had an expander. That's the case almost all of the time. There's nothing to gain from an upper-only expander. What's missing is all the other ingredients that are in part of treatment, in that you not only need an upper and lower expander, but you could treat a child earlier with guidance appliances. There are guides out there that work beautifully early. Guides have been very effective. I've been using those for 21 years. But there are two other big pieces of the puzzle that need to be offered to children. One is myofunctional therapy. And so if a parent is in an office and they don't believe in or do myofunctional therapy, or won't refer you to a myofunctional therapist, that's a red flag. You need a myofunctional therapist because it's the musculature that's not cooperating. So when you have an upper expander and you move it, well, the muscles are still poorly behaving. So of course it's going to go back to where it starts, because your teeth and your jaws go where your muscles dictate they go. It's the same reason all the teeth shift back after braces. Braces will force your teeth straight, but when your muscles are not behaving properly, your teeth are going back to crowded because the tongue is weak and the outside is strong. The weakness and kind of compensating of the muscles is how you got this case to be crowded in a bad bite that's going to be going right back. So the next level of tragedy is that the child coming to the office at age 11 or 12, and the parent says, well, we had an expander when they were 8. Well, when we went back at 11 for part 2, they said, oh, we did everything we could early with that expander, but it wasn't enough, so we have to take out the teeth now. That's a weekly occurrence in my office. The families that come in and say, we wanted another opinion because we thought we did the early work to avoid extracting teeth, and now we're being told we have to extract the teeth. So, well, the early work was ineffective because an upper expander only, again, the research says it won't work and be stable and relapse, so it follows that the research is there. The next level would be that now you have to extract the teeth, but the parent is basically being told everything was done that was possible. But that's not the case, because when we ask the questions, you had an upper only expander. That's not everything that was possible. Did you have any myofunctional therapy? No. Did anyone look at, and we say the word Frenon, but tongue tie or lip tie? That's a thing. Tongue tie and lip ties prevent the jaws from growing well. And when we have some sort of tongue or lip tie, it does prevent the jaws from growing well, but it also helps the teeth and jaws return to the size they were originally if we're fighting against those. So we do need the parents to dig deep and say, oh, an upper expander only. Why not the lower? What does the research say about an upper expander only? Because that's real. And then what about myofunctional therapy? What about retraining the muscles to cooperate and actually help us? So what we do is we incorporate all of it to help the child, meaning it's collaborative care that heals a child. We need early treatment as early as 3, and if not 2, if you're a pediatric dentist, you can work at 2, but 3 and above. We have to start where we see the trouble. Number 2, are choices. We have lots of choices to help that child, but it has to include myofunctional therapy, and it has to include tongue and lip tie assessment, at the least assessment. We never force anyone to do anything against their will. We would never tell a parent, you have to do something. We're educating and sharing, and then the parents who believe that this is going to help their child will do things. And there are some parents who say, I don't want to do a lip tie release or a tongue tie release. We're okay with that. It's their decision to make, but we've educated. We've at least shared and said, this is part of our issue. And what it means then is we'll do everything else that they're willing to do. We're cooperative and collaborative up to the point that's agreeable to the parent. So we do meet some kids where that's an issue, but more of our parents, when they do their research and they dig, that's going to be a good choice for us. It'll help our child. So more and more do it. So we want to have options. Guidance appliances, very effective. I've used those for over 2 decades. People who say guides don't work, they have no experience and no education in guidance appliances. If they do, and they're getting bad results, they have a technique with a defect in it somewhere. There's something wrong, because my entire team and I have watched for 2 decades guidance appliances heal children across all things that are growth and development related, because we're treating the malocclusion, and the guides redirect breathing and muscles. When you redirect breathing and muscles, you get a different child growing and developing. So it's a good thing. Expanders, when it's upper and lower, again, all of these get combined with myofunctional therapy and Frenum releases or lip and tongue tie assessments. That's a pathway to really help a child. The last but not least is nose hygiene. Kids don't have good nasal hygiene, so we need to teach it, support it, provide natural products to do it. So we could do it multiple times a day. Multiple times a day for nasal hygiene helps out a lot. When these things are done early, you can help redirect a child at the jaws. Growing the jaws helps the breathing, helps the sleeping, heals the child. So that's kind of what is the opportunity for parents out there. They just have to keep asking good questions.
A lot of the things you just mentioned are tooth pillow. Can you explain to listeners what in the world is tooth pillow, and why is it so amazing, and how can it help these kiddos? Just a kind of like a quick summary of what it is and how it's helpful.
Sure, absolutely. So 10 years of using, early treatment, a lot of it had to do with guidance appliances, then learning about myofunctional therapy and referring to, myofunctional therapists, and then doing more nasal hygiene over time. When the puzzle pieces came in, I started teaching this so that more kids would have access. But fast forward another chunk of time, and I realized, I'm really not making a big difference here. My own community loves this stuff. We're doing the early treatment. We're using the guides. It turns out in our own practice, we have a nice rate. 25% of the kids that we use guides on never get braces at all. And that's wonderful that 1/4 of the kids we use guides on never get braces. But the 75%, I understand 75% is a big number. However, when the guide has helped the breathing and the musculature and you get the jaw growth back, you're healthier, you're breathing better, you're sleeping better, the symptoms have faded away. When you're healthy and you just have a little bit to do with the teeth, the 75% of the kids can have clear aligners. We could do some clear aligners when they're a teenager, or we could do some braces when they're a teenager where you've already done the foundation. So when you've got a good foundation and you make a little bit of braces, we're talking about 6 months. 6 months of braces or aligners when you're older. And this experience with guides was so profound that I started to teach other offices so they would have this opportunity. But fast forward, it's really about 2 years ago where a couple of people, Chad Rasmussen and Michelle Grasmick, I have to give them really good credit for this because it was not my idea to try to bring this to the masses. I was trying the hard way, which was, let me go teach another office somewhere to do it and treat a few hundred kids, right? Their idea was the things that we're doing can be done remotely. We can do this with the teledentistry model. And one thing we learned from COVID is you can do a lot through a computer. Now, I can't fix a tooth through a computer. I can't fix a cavity through a computer. However, I can monitor and kind of recommend and treat a patient with guidance appliances, with nasal hygiene, support products and techniques, and myofunctional therapy can be done via Zoom or through a computer. So all of a sudden, you combine these 3 things. Well, guide wear, that's at home. It's all on the compliance at home. If a child wears it well and the parents are supportive of having that guide in, we can do wonderful things. Myofunctional therapy can be through Zoom. We can do that remotely. Nasal hygiene can be through team support. These parents get them using, nasal hygiene products and techniques all day. Well, combining the 3 things adds up to what Tooth Pillow is. Tooth Pillow was basically born out of solving for access, number 1, and affordability, number 2. Access. Any child can benefit between 3 and 12 from having a guide, nasal hygiene techniques, and myofunctional therapy. When you combine those 3 things, based on my 2 decades of using them in the office, every child could benefit from this opportunity. So we now have a way to give access to parents who are in places where they'll say, I don't have a myofunctional therapist near me. They're about 2 or 3 hours away. We can connect them remotely. Then, of course, the other thing is, the airway dentist that we've mentioned a few times, having an airway dentist, are they actually working on the kids this young? Because they may say they're an airway dentist or they may not be one, but the nearest one is 4 hours away, 6 hours away. There's nobody near me that wants to treat my 4-year-old or my 3-year-old or my 5-year-old. They want me to wait. Well, access. Now the parent can submit their child to Tooth Pillow, and basically they're submitting the sleep breathing questionnaire so we can learn about the symptoms, again, screening the symptoms, but also a set of photographs that we can take a look at that child and say, that child's a wonderful candidate for this. We should allow them to have access to this. And then affordability was very simple. Removing a brick and mortar dental office reduces a lot of expense. Turns out now that we've done beta testing on this for 2 straight years, we know it's a fraction of the cost to do this remotely. So any child between 3 and 7 can benefit from guides, myofunctional therapy, and also nasal hygiene. And that is what Tooth Pillow is. Tooth Pillow, like a system, we have 3 things to do for the child between 3 and 7. And almost all of them qualify. It's 8 to 12. Unfortunately, 8 to 12, I do have to deny some children Tooth Pillow because between 8 and 12, there are symptoms that get too severe. And the photographs I can see, this child is way too narrow and way too crowded. The Tooth Pillow system isn't going to get them there. The guide and the therapy and the nasal hygiene won't be enough. So I have to deny, and it turns out it's about 25% of the kids have to be denied. And it's heartbreaking. However, we don't stop right there. We try to redirect them to an office. So now that we've met that child and we've seen what they have, 25% of the 8 to 12-year-olds that we deny, we immediately start to help them find an office that they can get to that will know what to do and how to do it for them early. So we take it one level past the denial and try to get them in the right hands. Because yes, their child does need to be treated now. They don't need an upper expander only. They need an upper and a lower. And usually they need the myofunctional therapy and the Frenum releases. So there are that group of kids. So Tooth Pillow is basically a remote pathway to offer early treatment to kids in categories that they could only benefit from and can only steer them in the right direction. It is certainly better than doing nothing. And it is, leaps and bounds away from taking out teeth and treating the kids later. So we're very happy. We've done beta testing along the way. We have several thousand kids in treatment now that we're monitoring. It is doctor monitored. We have not only an entire support team that handles and basically interacts with the parents daily, weekly, and monthly. But we do have treating providers. We call them treating providers, but they are licensed doctors in every state who have been trained to do these early treatments so they know how to monitor the children. So the parents have a full support team there to help them on a daily, weekly, monthly basis. And then we have a doctor assigned. Every child has a doctor assigned to them to monitor the pathway over time. And this Tooth Pillow gives access and affordability to parents anywhere.
Thank you, Dr. Ben. And I know we're coming up on an hour, so I thought we could wrap it up with one last question. And so we talked about hurdles, so families, access, education, affordability. And now working with these families at Tooth Pillow, we've discovered another hurdle. And I don't mean to pick on dads, but there are so many moms out there that will say, I'm just trying to get my husband on board. Maybe they're the naysayers or they're a little skeptical. Do you have a message for them or anything to say to the dads to help these moms get dad on board?
Yes, I'm familiar with this because in the submissions coming, we do learn that it turns out most of the time the mom is doing all the research. And so when mom is doing all the research, she is spending a lot of time and energy learning all about this. And it can be hard to share it and pass it along because of just the daily routine. And the daily routine can make it so that everything the mom is taking in, absorbing, and learning doesn't get transmitted over. So there's that little bit of that lack of the full education that the dad isn't getting, but the mom totally has. And sure enough, this is totally new to anybody because I'm in my office for 21 years. And when I get a guide out and I show a parent and I say, this is what a guidance appliance looks like, they'll say, I've never seen or heard anything like this. And they're decades old. I mean, decades ago, this was invented and done, and it just was never something so popular. So nobody knows it exists, but it's not a new thing. And so every parent pretty much says, I've never heard of this. It's new to me. I don't even know what this is all about. It takes time. In my office, we do focus on teaching both parents. So in an office setting, I can have both parents come in and have a consultation. They both learn at the same rate and see it all together. That is very effective. But what we're doing here with Tooth Pillow, of course, one parent might find us online. Typically, it's the mom. They'll have done a ton of research. They'll send in the child. We'll approve them. We'll actually screen and approve. But then the hurdle is dad's not sure about it. So, I mean, it is difficult just to say, oh, do whatever your wife says or do whatever your partner or spouse says. That's not the best answer. And so I think that based on my 20 years of using these in the office and how effective and appropriate and a wonderful opportunity these have been for children early, I would encourage dads to listen to this story. And so while there are some things that are out there that you might disagree with, there's definitely a pathway to hear everything that your spouse or significant other has done the research on and share with you, because we only have an opportunity to treat your kid between 3 and 12 when they're between 3 and 12. The 12-year-old doesn't get this opportunity very often. So we can help a child early, but not when they get to 12. All of a sudden, we missed our window. So it's nice to have an open mind. Have an open mind. Allow your significant other, spouse, partner to share what they have learned. And then, we at Tooth Pillow do go the extra mile. We're not opposed to having a phone call. We do believe in giving everyone their opportunity to learn. And I have gotten on the phone. It's become now a weekly occurrence where every week there are multiple families we'll talk to, because whether one is on board and one isn't, or the family's struggling to find someone that they can get help with locally because they can't have Tooth Pillow, we're more than agreeable to try to help in any way. And if it were to help to have a phone call, I usually make myself available. It is nice to learn. And so with the education, comes good choices. So be open-minded, listen to all of this and dig yourself. It's okay to go and check out our website. We built the website, toothpillow.com, to be educational for parents so they could all see everything that goes into it, to learn the connections and the research behind it, so that they would know, like, oh, I am making a good choice for my child, and they're only going to be 4 once or 5 once or 6 once. I don't get to treat a 4-year-old when they're 8, or, and so on. So yeah, please listen, be open-minded, take it all in, then make a good choice.
And make sure to do the consult too if you know that your husband is a little more on the skeptical side, or maybe the roles can be reversed. It's just more common it's the dad. Because I did have a family that said having that consult video so that their husband could sit down and also watch it and hear straight from the provider was really beneficial in what they needed to help get dad on board as well. And and once you are in treatment, it's a group effort. It's not the easiest. Everybody needs to be involved, on board, encouraging. So it's nice when everybody is, supporting each other. And I was just going to pass it over to Amy if you have any last thoughts or last questions for Dr. Ben.
Oh, I was just going to say that dads are usually the ones crunching numbers too. And I can only speak for my own personal case, but, we were driving 2 hours one way to have these consults in office with different dentists. And it's like $250 to have a consult. And then, you might not even go with them. And then the provider we did go with, it was these, we're driving 4 hours round trip to see them. So it's gas. Sometimes we'd stay overnight because we'd have an early appointment. The cost of this upper expander only was more than double of the price of Tooth Pillow treatment. And then we went to Tooth Pillow after, and there's maybe more expansion. There's things. So when you're crunching the numbers, which I know dads and moms, but mostly dads love to do, yes, Tooth Pillow really does make sense. And they're hitting the affordability and accessibility right on the head. So it's absolutely worth looking into. And I did have one more question for Dr. Ben, just because I haven't seen you go in depth on this one, but you did mention ear infections a couple times. And I know that is a topic that is brought up to me many times. And I personally don't have the science behind it, but I know that swallow pattern can play into or cause ear infections. How can an ear infection be caused or related to your oral function or dysfunction?
Sure. Yeah. So again, the sequence of events, if we go way back, we got this early soft diet jumping in. So the mush, the baby food. Well, the early soft diet delivers a weaker tongue. So basically what happens with breastfeeding early is that the tongue is strengthened appropriately and is basically taught proper function. When we go to hard food, the tongue is maintaining its strength and function. But when we switch to softer food, the tongue loses its strength with softer food. Now, the tongue is a muscle, just like the rest of our body. So if you think about, if you go to the gym and you work out with a trainer and you do it for an amount of time, you're going to see a difference. Like the muscle group you're working out is going to be bigger. But when you stop going to the gym and you don't work out anymore, you will lose that muscle strength, tone, size. So just because we built something up doesn't mean we keep it. You have to maintain it. So the tongue is just like that. With the early soft food, the tongue is going to lose its strength that it got from the breastfeeding pattern. So now we have a weaker tongue, a weaker dysfunctional tongue, meaning it's swallowing differently. Well, it's the inappropriate swallow. The poor swallowing pattern, which is basically compensation for the softer foods and the weakness in the tongue, the poor swallowing pattern basically prevents the fluid from draining out of the ear. So in the ear, we've got fluid that is formed, and basically every single proper swallow causes the eustachian tube to open and the fluid to come out. So if the eustachian tube is always closed, it's a proper swallow that opens it. There's a muscle that does that. So this fancy word, tensor veli palatini, that's the name of the muscle that opens the tube to drain the fluid out. But that muscle only works or contracts when we swallow properly. You have to have had proper tongue strength and function to swallow. The soft food gives you the weak tongue, the dysfunctional tongue, it stays low. When the tongue doesn't swallow right, the eustachian tube stays closed. And when it stays closed, the fluid builds. And when the fluid sits too long, it increases the rate of ear infections. So the rate of ear infections goes up in children as industrial Western living takes over with that early soft diet. It's a direct result of the poor swallowing pattern. So the poor swallowing pattern is what causes an ear infection. And to treat the cause of an ear infection, what you have to do is get a proper swallowing pattern going. And that is done by guidance appliances help redirect the tongue to swallow better, as well as myofunctional therapy. And the last item would be the tongue tie issues. When the tongue is tight, if the frenum is too tight, you do help to release it, then you can have a tongue function properly and get back your swallowing. So it has been our experience that delivering proper tongue function is a pathway to see a reduction in a symptom like ear infections. So it's been for 2 decades that case in our office, but then you go and you dig and you can find actually how the ENTs, there are some out there who make the YouTube videos that teach how this all happens. And I came across it that way. It took a long time to figure it out and find it because you get little bits and pieces here and there. Nobody really explains the whole thing through. But the early soft food delivers the weak dysfunctional tongue, and then that produces an improper swallow, and the fluid won't drain, and it builds up, and you get an ear infection. Treat the cause versus the symptom. Big difference.
Thank you. It is so interesting to me how something that seems so small, like oral dysfunction or improper breathing, can cause these systemic issues. Like you've addressed everything from the head down to digestive issues and everything in between. And so I just hope that we're able to get this word out there because it is so important, especially for kiddos, but adults too, just to have this understanding how something that seems so small or so common is not normal and really does cause lots of issues. So, and we can help.
Yes, we can. I left out one little detail too when I was saying about the digestive issues downstream. That's another one that's related to the poor swallow. So that is a short story. I can make it quick. The poor swallow, actually what happens is that the child starts swallowing air. So a proper swallow, we don't swallow air, but when we have the poor swallowing pattern, we swallow air. Swallowing air into the digestive system is what causes a lot of the digestive issues downstream. Poor sleeping and breathing, the quality of sleep affects the digestive system, but even before that, the swallowing of the air is contributing to the digestive system dysfunction that we see, whether it's reflux or diarrhea, constipation. Digestive issues are related to swallowing air. Swallowing air happens when we swallow poorly.
And I know there's so many moms and dads and, just like thinking, oh my gosh, this is me. Oh my gosh, this is my kiddos. And connecting all of those dots and putting the pieces together and realizing that this, how it all is related. So we really do hope that reach out to us. You can email us, submit your child, and, go right to Dr. Ben's desk. He will lay eyes on them. And even if we're not the answer, he is so gracious. We will help you find the right answer, get you in the right direction. It's the perfect first stop. Maybe we have to tag in other players or refer you somewhere, first, but it's the best place to start to find some answers. So we're so excited. Thank you, Dr. Ben, so much for spending the past hour with us.
My pleasure. Thank you for having me.